Thank you, Dr. Swaraj, for having me here. It's lovely mid-afternoon or early afternoon, you can say. And nice to see all familiar faces from my state. I am still, though I work in Calcutta, I am by heart, by soul, an Okhomia. So I feel that I am back with my roots. Thank you. So I'll be speaking something on high myopia. Now, being in practice for 20 years, definitely, and shifting more towards refractive cataract surgery, other than the routine, high myopes coming in, and my partner, he is more of a refractive surgeon. He goes for any high myopia, goes for ICL, and I oppose ICL. I say I do refractive lens exchange, and he opposes me in every forum. Well, if you take real precautions, even in high myopes, because again, just a prelude to that, why RLE you can do if you have seen the retina, if you have seen the periphery, because then every person would be having retinal detachment, because we do it. I mean, we are doing high myop cataracts, but do they end up in retina? Because we take all those precautions. So RLE is an option if you have seen if you've got the right person. While high myopes, as 5 to 20% of these patients do have cataract, the issue is the maculopathy and the amblyopia. That's the first thing. Is the patient amblyopic or anisometropia? And something else is maculopathy or high myopes. When you talk of high myopes, anything between 7 and 8, but we are looking at something like -12, -14, those patients. So the cataract can be just a nuclear or posterior subcapsular cataract, or in if the patient comes too late, it can be the heart cataract or whatever cataract may be. So when you see these patients, it's very important. You do a cycloplegic refraction, see the astigmatism is there or not, and look at the pupillary size. Most of the people would dilate very well, but there would be cases where dilatation is a problem. The cataract density under type, and many of these high myopes actually on table, especially the spherophakes, early spherophakes. You thought that this is absolutely high myop. The moment you take it in the OT, maybe it's dilating, mid-dilated, you are not seeing. The moment you put viscoelastic, make the anterior chamber dip, and you see it's basically a spherophakia grade 1 or something. So subluxated cataract or spherophakia can be a presenting symptom as a high myop. We have to be ready for that, and the AC depth and all becomes dip, and the scleral rigidity is less. Fundus examination, as I said, foveal contour or phobia you have to see, because you have to promise them a good result after surgery. Retinal periphery, you have to look for PVD or liquefaction of vitreous. Once you remove the cataract, the PVD symptoms should increase, so you have to counsel the patient. You can see more floaters, more dots, because whatever steps I'll be saying, you would still would be inducing some sort of PVD, even if the PVD is not there in the high myop. So they would start complaining of floaters other than the dry eye symptoms. That would bother you more in these cases. So prophylactic retinopaxy, I would do it. Being a retina trained person, I see some retina guys also. If you think that you are not able to visualize the periphery well, take a help of your retina colleague, and definitely they can, even if you are can do some of the peripheral degeneration, but with the indirect ophthalmoscope, with the indirect laser, the retina surgeon can reach the periphery and give you that protection before going for these cases. Anything above 26 millimeter is definitely axial length risk. There is a danger of PVD, CME, compromised zonules, as I said, and other thing that Dr. Deepak Bhuiyan just said, the retropupillary, reverse pupillary block, that is what you might meet in your surgery. IL power calculation, we have got plethora of formula, but this is what I said today with the universal Barrett formula that covers most of the thing. In case you don't have it in your biometry, you can download it and fix in those values. You get near correct, or otherwise Haig's formula is supposed to be. But if you are still not, SRKT will give you reasonably good result. That's what has happened with most of us today with going for RLEs and going for the advanced lenses. Probably we are using more of this universal Barrett formula. You need to spend some time with this when you do this. And the IOL choice, square edge, 360-degree square edge. We don't have 6 or 6.5 more than 6 millimeter lenses normally, except the Rayner lenses are probably 6.25. but the others are 6 mm, but ideally would be around 6.5 millimeter lenses, so you have wider areas of coverage. The rexis size, as I said, little bit has been told by Dr. Swaraj about the head position, and I just said the head position, low microscope illumination. These are some things, how you sit in these patients is very important. And the surgical technique, basically all steps must be taken to minimize the instability of anterior chamber, thereby minimizing the anteroposterior movement of the lens zonal diaphragm. Phacoemulsion and the fluidics with a small incision are said to reduce forward movement of the vitreous, and this is where the advanced phacoemulsification machine like Centurion, I just no financial interest, probably that's the machine that would give you that fluidic balance where there's active fluidics. In these cases, normally you would keep the bottle height low and again bring the bottle height in a normal machine. These are the ways that you can see. Now about the surgery, well, I won't come to these steps. I'll just show 2-3 videos which will give us Now, if you look at I was saying what the problems during phacoemulsification. This is a video, something I was not aware of, some 15-year-old video, which those or 18 years back, when I was not so aware what are the problems that I would face in a high myop. This actually implies, I show it in almost all the, see, look at the AC is becoming shallow. These are the problems that you can face. Now look at, this is a straight tip I am using in those days. See, I'm trying to go, look at the depth, the way the phaco handle is going down. So you're not getting the right hold, and the fluidics is not here. So every the occlusion is occurring as I'm trying to live. I'm trying to do all sorts of maneuver. Well, I managed to break the nucleus, but then see, every time I am trying to get that and the AC is becoming deep. This is, yes, there is the retropropulsion syndrome, but it's not happening that much. See, the iris has come out, the AC has become shallow again. And then again putting in a viscoelastic, basically tapping from the side port, getting the iris down can help you in these sort of cases. Look at this, get sight from the periphery, exactly, because you cannot chop it so well, because the depth that is there, you have to go down, and that's the way you go down. And so just how to avoid the anterior chamber shallowing. Now this is the one that I would do presently, and once I've taken off the most of the, I can see the hydrodissection or hydrodelineation, the phaco part. Well, I'm trying to stay in the periphery, trying to do the cartwheel technique, but get it from the periphery, because if you're going to get it towards the center, because every time you take out your instrument, see that you push, make it, some surgeons have a habit of doing this maneuver, putting in viscoelastic, every step you take out, but if you follow it in case of, definitely in high myops, that's a big help. And just talking of the cartwheel technique in the softer cataract, because most of them are soft cataract. Just a minute, as you can see, the rexis, so get it, fold it from the side. So if you're trying to go in the center, probably it will become deep. You may not be able to, chop it. So go to the side, and this is the cartwheel technique, where you get the periphery or mid periphery of the nucleus, rotate it, and it comes down and back to you. Just to continue with the presentation, a few more slides, I think. That's it. Yeah, post-operative assessment. Well, do the cornea and do a regular checkup. See that the periphery is okay. Periphery, if there is, whether even if these techniques, whatever method you have done, you might end up still with peripheral retinal breaks. And the yak capsulotomy, well, this again is high. Try to do a capsular polishing and try to clean the peripheral of the anterior rexis margin, the rim, so that the need for YAG is as much as delayed as possible, because the chances of retinal detachment is as high as 0.9 to 10%. There has been advocate of people who propose a primary posterior capsulorhexis, but I don't follow it. I don't know if anybody follows it. And there's the UVM picture, how the lens positions itself at the end of the surgery. And the risk of retinal detachment, as I said, is almost the spontaneous retinal 40 times than emmetrops in after phacosurgery. That's what one of the studies suggests. So this is one more. We can take risk of anterior posterior movement. That's the only way we can do it. Just reduce the risk by minimizing the anteroposterior movement of the lens or zonule. So using a better machine with a better fluidic control so that you do not have any fluctuation. I would rather use a low the vacuum around 215, a normal machine around 300 instead of 400 and 450. Keep the bottle height around 90, and then lower flow rate, make the surgery slower or lower, and always skip a side port with a viscoelastic, whichever steps you follow. Thank you for your patient hearing.